Good morning. I'm very happy Dr. Vijayakumar has been able to organize such a beautiful meeting, and he has been my favorite student, dynamic person and a very good organizer. Thank you, Vijayakumar. And Dr. Kirmani, your talk was very motivating, and in fact, that will be a good prelude for my talk. So he asked me what topic you want to give. So I just thought, after working for 50 years in diabetes, instead of just talking on science, I thought I'd talk about art of diabetes care. Well, as clinicians, we have many challenges, and one part I'll talk a little science and then talk about the art. We have a delayed diagnosis in India, and you will know how to do this, how to measure this, how do you know that actually you're delaying. And I'm going to give you a couple of studies which we have done to show you that we have actually documented and measured the time taken for people to have developed hyperglycemia and to come to your clinical care. And then you have lack of awareness and difficulty in continuity and motivation of patients. Dropouts are very common in our country. Of course, we have big problem in faith in alternative system of medicine. Even today, even with so much of education, people go and get alternate system of medicine treatment. And of course, many of the elderly people have to depend on families, and the family support is a very important component of the disease which we often forget. And then you have the influence of the social media, and you know that you have even false beliefs coming through that. I'm not going to talk about economic barriers, medical education. Of course, a word about medical education. All of us have gone through the MBBS curriculum, and all of us are very good doctors in treating. You know, an MBBS doctor is very good in treating a patient with hypoglycemic coma, because the blood sugar is 40 and he knows he infuses glucose, patient gets up. But the only problem for him is how to control his diabetes for the next 30 to 40 years. That we are not good. So we are not prepared for, we have been not trained for chronic medical care. In fact, our system also is not allowing that. And that has to change over the years. So I'm not going to discuss on these. So let me give you 3 studies which we did our center to tell you about delayed diagnosis. And you may wonder how we measured it. And it was very innovative study. The first study was, we took all the patients who were clinically diagnosed in 12 centers from 3 southern states in India when they were walking into the clinic. And all these subjects represented the clinical profile of newly detected diabetes in the clinics that you see in our place. And then what we did was, at the same time, we were having a epidemiological survey in the population, and we know the people who have undiagnosed diabetes, asymptomatic diabetes in the population. So we compared the undiagnosed diabetes in the population with the diagnosed diabetes in the clinics. And so what happened was, there was a difference of almost 1 milligram of HbA1c. So the people who have hyperglycemia in the population has an HbA1c of 8.3. By the time they reach to the clinic, it has become 9.1. This is real. And look at the second one. Almost 70% of them have HbA1c more than 8. 45% of them have an HbA1c of more than 9 before they come to your clinics. So it's a delayed diagnosis. The other important thing that we did was a very innovative study, and that is, we looked at, my professor in MD used to ask me a question, very simple question. What is the bedside test to diagnose type 2 diabetes in an adult who is with you? And the answer to that, the MD answer was, look at the fundus and you look at the microaneurysms. If you get microaneurysms, you don't have to do any test, patient has diabetes. So what we looked at in this particular study was that we looked at 1,000 type 2 diabetic patients of different durations. And then using a weighted linear regression, we looked at the fundus for everybody, very detailed ophthalmic examination to identify retinopathy, because retinopathy is a marker of duration of type 2 diabetes. As the duration increases, the cumulative prevalence of retinopathy increases in any population. So what we did was, we looked at, this is a very complicated statistical method, and this is called weighted linear regression squares. What we did was, we plotted the prevalence of retinopathy according to the years. On the x-axis, you have the years. And when you get to 0, still you have retinopathy. 6 to 7% of people still have retinopathy. So the statistician did what is called a regression model and said that by the time the diagnosis is made, they have already had to have diabetes for almost 4 years. So this is that we have calculated that in Chennai, at least, way back in 1996, we have 4.1 years is the average period from onset of hyperglycemia to clinical diagnosis. The next study is a little more interesting study, and that is, we are looking at patients who had acute coronary syndrome, either acute myocardial infarction or acute left ventricular failure, who are getting admitted into intensive cardiac care units in Chennai, in 2 centers. And what we did was, we excluded all the people who had known diabetes. So now the question is that, how many people will have diabetes who did not know they have diabetes when they had acute myocardial infarction? And it is pretty surprising. So what we did was, we did the fasting plasma glucose every day in the ICU, and diabetes was diagnosed according to the WHO criteria if there was diabetes, and they were treated for diabetes. Others underwent an oral glucose tolerance test before the discharge from the ICU. And the strength of the paper was that all the people were retested after 3 months to see whether they had continued to have impaired glucose tolerance or diabetes, because you have to exclude what is called stress hyperglycemia. And what we found is very interesting. Can you imagine? 46% of them had impaired glucose tolerance, 38% had newly detected diabetes at that time. I mean, they had already had diabetes by the time they came with myocardial infarction. Only 17% were normal. So we compared this with the European populations, and we found that we have the highest rate of diabetes in those people who had heart attacks. In other words, it looks as if the high prevalence of diabetes in the populations is driving the increased incidence of cardiovascular events. And this is one of the papers which is published in Diabetes Care only by the editor without sending for a review. So now come to the art. I'm sure you see patients every day. And we think that, as Dr. Kirmani said, you're just writing sulfonylurea, metformin, SGLT inhibitor, and then giving the prescription is the treatment. And you expect the patient to follow whatever you have done for the next 30, 40 years. Do you think it will happen? What are the reactions to somebody who has diabetes? I'm sure that even youngsters get diabetes. Any one of us can have diabetes today, and we do not know that we have diabetes. The first thing is a disbelief. And I have very commonly seen patients saying, well, I think that is wrong. So what they do is they have to try to change the laboratory. You know, there's an old saying, one of the best ways of reducing cholesterol is to change the laboratory. So similarly, so they do not believe the number, so they go and test another place. And the other one is anger and neglect. And of course, there's a sense of guilt. Many people say, oh, I took a lot of sugar and sweets, and that is why I got diabetes. And of course, anxiety. Eventually, they accept. So these are the stages that you see when somebody gets diabetes, which we do not realize. We always think about only the blood sugar and the medicine that you have to give. So at the diagnosis of diabetes, who has walked into your clinic, you must understand this is a lifetime disorder. Not exactly curable, perhaps reversible in a few who are very obese and very young. The advice to change lifestyle is to reduce stress and etc. Now, these will require drastic change in every aspect of life of an adult who has been accustomed to certain habits in the last 50 to 60 years. As a physician, so look at the last sentence. This is a routine work for us. Every day you see that. However, we are taking full authority to change a person's life. And you expect you are doing a service to him, right? But imagine the change that is occurring in your consultation room. And that is the art. So, what is the reality? And Dr. Kirmani was telling. Usually there is silent hyperglycemia, and most of our patients, I don't think we should blame us, remain uncontrolled despite available treatments, and they may not come for because it's a symptomatic disorder. And of course, we don't think we have to be always blaming delayed intensification, and I think Dr. Kirmani talked about that. So there is something called inertia, and I think it was mentioned in the previous talk. Now, inertia is from both sides. I don't think we should blame ourselves all the time. Of course, there is inertia on our part, and for the reason for that. Why don't we want? I'm going to come to that in a moment. Clinical inertia is defined as the failure of the doctor to initiate or intensify therapy when a patient's clinical condition indicates it is necessary. But there are 100 reasons not to do that, and I'm going to come to that point. From the patient's point of view, failure to initiate, non-adherence, clinical disengagement, behavioral inertia. You're telling him, okay, for tomorrow onwards, stop sugar, sweets, walk every day 30 minutes, don't do this, smile at your neighbor, don't fight with your wife, all that you can go on telling. Do you think he will follow that? Okay, some of them are good. And that is art. So what are the barriers? Of course, pure communication skills. I have in the last so many years found that the best brilliant doctor who comes out of the MBBS is not the most popular doctor. The most popular doctor is somebody who has good communication skill, who can talk to the patient, who can actually tell him what to do and also convince him to change his lifestyle. Of course, illiteracy is a problem, lack of awareness of adherence issues, insufficient follow-up, not addressing patient concerns. And I'm going to come to that in a minute, and that is art. So the physician factors from our side is that, of course, there is a fear of hypoglycemia. If I start somebody on a higher dose of medicines, this patient will go into severe hypoglycemia at 2 a.m. in the morning. Two things can happen. First thing, he can call you and disturb you at 2 a.m. in the morning. The second thing is, the hypoglycemia can be such a dreadful experience, he has the good option of changing the doctor, which you don't want. So you don't want to increase. Poor outcome expectations. The patient does not know that if the blood sugar is 250 or it is 150, what's the big difference? I'm okay. And he will always blame, no, it is 250 because yesterday there was a marriage, sir, so I took some. So now you have to tell him, no, 250 is not good, you should not. So you have to make him understand it is not good. It's good for to go for the marriage, but it is not good to take the sweet. Okay, the other thing is, why there is no immediate results from correcting the blood glucose. So it's not rewarding. The patient is not going to call you and thank you and say, I'm going to send you a gift because my blood sugar from 250 has come to 150. That will not happen. I'm going to give you, a very important information here. I've been telling this. A 55-year-old man walked into your clinic. He's a BIP. His blood sugar is 290. He travels a lot, under a lot of stress, we are not seeing him very regularly. Now, what is your motivation to spend another 45 minutes to 1 hour with this man when another 10 people are waiting outside in your clinic? To do everything possible and brainwash him to bring his HbA1c to below 7%. What is your motivation? It is to prevent his heart attack 10 years from today. Is it not? He will say, Hare, it is 250, so if you bring it to 150, from 9 to 7, what will happen to me? Oh, I'll try to prevent a heart attack for you. When? 10 years from now. How much of interest you have in that? And he will say, I'm all right completely. He has to wait for 10 years to see the results of what you talk to him for the next 45 minutes. And also you can say, okay, reduce the kidney failure. Unless his mother or uncle had kidney failure and going on dialysis, then he will be motivated. Now there is a story for this. Now, is there any way all of us can be motivated to do that 45 minutes talk with this patient? There is only one system in the world where they have tried this. As you all know, the best medical health delivery system in the world is the NHS in the United Kingdom. Okay? Even the Americans are not able to do that. So, what they did was, they did what is called an incentive. For example, if the HbA1c is better, you do not charge the patient double the consultation fees. Do you? You don't. You cannot do that. He pays the same fees only. So, whether it is 9% or 11% or 7% doesn't matter as far as today is concerned. You get the same fees, you see the same thing. So that didn't happen, unless his wife is sitting and saying, okay, thank you, doctor. So the NHS did what is called the Quality and Outcome Framework for Diabetes, and they gave voluntary incentive scheme rewarding GP practices. So the general practitioners were told, if you bring down their cholesterol, if they bring down your HbA1c, if you bring down their blood pressure, you get better remuneration. What is the best incentive for any human being? Money. So this is what they did. You know what is the result? Now, this is shown to have led to improvement in diabetes care in the United Kingdom. A large review found that the QoF increased quality indicators. In fact, one study showed the prevalence of retinopathy came down drastically. So that just shows that any motivation or incentive that we have can make us better doctors. Well, in India, I told you that when I see a patient whose blood is already on 5 oral hypoglycemic agents, blood sugar is 300, HbA1c is 9.5, I'll tell him, I think you must start on insulin. So again, there is a problem. He has again, I must say, I'm a good doctor, I don't want to give you insulin, but you need insulin. You can keep on telling that. But the problem is that he will go to another doctor who will say, you don't need insulin, I'll change the medicines. So, doctor, risk of hypoglycemia, of course it is there, which I told you. They are of course confused about several insulin preparations. Even today I don't know, because I have found that in fact oral hypoglycemic is very difficult. As Dr. Kirmani was telling, your prescriptions were 2 sulfonylurea, 2 DPP-4 inhibitor, DPP-4 inhibitor plus GLP-1. Of course, insulin also provided. So the fear of losing the client, the last one. As far as the patient is concerned, fear of needles, fear of hypoglycemia, and the patient say, once I am on insulin, I'll be on insulin for lifetime. How do you answer that question? And another patient told me, my grandfather took insulin and he died. Grandfather has to die anyway. Okay, the other one is lack of awareness of the severity of the disease. Blood sugar is 290, you are absolutely normal, but it gives you high risk of kidney disease, heart disease, retinopathy, neuropathy. They do not know that, so that's a problem. Okay, and there is no knowledge of the long-term benefits and social stigma of taking insulin, many misconceptions about insulin. So what patients often think in our clinic is that, I feel fine, I don't need any medicine. Diabetes is probably temporary, tablets are harmful, fear. I think that's a very common thing. They say, I am taking tablets, I heard that tablets will make the kidney fail. How do you tell? You must tell him the sugar only makes the kidney fail, not the tablets. Very difficult to understand. So the barriers to long-term adherence is lack of understanding, psychological resistance, denial and fear of insulin, cultural and dietary practices, traditional benefit beliefs, And then again, financial constraints and complex treatment regimens. You write 4 tablets, 3 times a day, 2 times insulin. I don't know how long you can do that. I find if I start an antibiotic for 5 days, I definitely miss 1 or 2 doses. You understand? Actually, my wife had viral fever when we came from Calcutta, and I told her, take this tablet morning and evening. She misses the tablets, the temperature goes up. My time is up? Okay. Influence of social media. I'm sure everybody is a Google doctor today, and so most of the patients already have Googled GLP-1 before they come to you. So that's another problem that we are finding is very difficult. There is nothing new to tell the patient because the patient already knows everything. So from the authority, 20 years ago, when you tell something, the patient doesn't ask a question. Today, patient will ask a lot of questions, and patient's son or daughter sitting there. Active listening is important. Please listen to the patient because it builds trust and rapport, helps uncover patient beliefs, and improves acceptance of long-term therapy. A very simple, this is a very old slide. A lady who just came to you and then you think her diabetes is very high, pressure is high. But look at her priorities. Her husband had a stroke last month and is bedridden. Daughter has come for her delivery. Her diabetes care is her last priority. Just now, when I was coming in the car, I read a news, and that is very important. Yesterday, Dr. Seth, Abhijit Shrikant Seth, was chairing a session in Ramachandran Medical College. He is the chairman of the National Medical Commission. He said a sentence, which I actually put in my slide already. And then he said was, behind every case sheet, remember there is a patient, human being, with a life story, with a family, and with a hope to get faster recovery. Remember that is a doctor. So here is somebody, Subbamma, who has got so many priorities in her life. So patients may forget what you prescribe, but they remember how well you listened. Okay, 2 more things and I'll finish, okay? This is because I've been seeing patients many years, this is really what happened, how sensitive and demanding the patients are. The first one is a pat on the back. Many years ago, when I saw a patient, this is about 10 years ago, a patient I finished seeing and he was waiting outside, and my assistant came, sir, patient is still waiting, he's not going away, 1 hour waited. I said, what? I called him back and said, what's the problem? Sir, every time when you go from here, you used to pat on my back and say, you will be all right. This time you forget to pat me. Really happened, I'm not bluffing. So that is the pat on the back. The next one, I used to have more patients sometimes, so I'll have 2 consultation rooms. One is a little larger room with a telephone and all the things and all that. The other one is a very small room. So many a time I see somebody in the small room and so one patient again waited for a long time and he said, doctor did not see me properly. So what happened? No, he didn't see me in the big room. Can you imagine? So that is the art of diabetes care. Lastly, we have guidelines. Who makes the guidelines? ADA or EASD? Of course, I have been in the guideline committees for WHO for changing the diagnostic criteria, which is very good. But most of the guidelines are based on data from Western countries. They are very complex and limited primary care integration. So guidelines are necessary, but not sufficient, not alone. Must adapt to local realities. Western-centric approaches need contextualization, balance, evidence, and practicality. So there are a lot of India-specific solutions. So take 3 take-home messages. Listening is essential in diabetes. Diabetes is a disease with which the patient has to live for life. Adherence is the key. Patients must understand the importance of lifelong therapy. So, key message about balance between medicine is both science and art. We are not treating diabetes, remember, but we are treating a person with diabetes. The human element is absolutely essential. Thank you.